Got to try to finish this up in this hour. Took a little longer than I thought. So, sleep can be broken down into active, multi-phase process. Okay, the hypothalamus is the major sleep center that's involved. Okay, it promotes wakefulness and rapid eye movement. The two phases of sleep are basically rapid eye movement sleep, which is called REM sleep, and non-rapid eye movement, which is non-REM sleep. When we put people under general anesthesia, we're basically inducing a non-REM type of sleep. Okay? You never see anybody REMing while they're under anesthesia. So we're not inducing a situation where they're actually getting rest. Okay? So people still feel tired when they do wake up from the anesthetics. You can see that the EEG stages of wakefulness and sleep. What you're actually seeing is that you go from a wake state where you have spindles and active phases. Then you go into stage 1 and stage 2 where you actually sleep spindles. Then you go into stages of hyperactivity, which is stage 3 and stages 4. Okay? 75 to 80% of sleep time is spent in non-REM sleep. Okay? The 4 stages that are evaluated by EEG can be either stage 1, 2, 3, and 4. What you're looking for is in REM sleep, you'll see a hyperactivation of sleep spindles that are developing. 25% of time is actually spent during sleep time is REM sleep, also known as paradoxic sleep. It occurs about every 90 minutes beginning after the first 1 to 2 hours of sleep. Okay? The normal sleep cycles that you see is that you go into these phases and you'll see that the person goes into REM sleep and it gets prolonged. Usually you'll see that by the end of the evening when you're waking up, you actually have very prolonged REM sleeps. Okay? As you get older, your REM sleep actually shortens, okay, and actually alters. Okay? We don't really know why people really need to sleep. We've seen people that have been injured and never sleep again, okay, and they actually read, or they sit in bed and rest, but they don't really sleep, and they're perfectly okay. Very strange, because about a third of our life is spent sleeping. So you imagine if you couldn't sleep at all, imagine what it would be like. It'd be like you used 1/3 more of your time to be useful. Okay, so yeah, it felt so good, right? No, but actually, most likely there's some functions of sleep. One time, a lot of scientific discoveries have been done while people were sleeping, because the problems that you actually think about before you go to sleep is your REM tries to resolve it for you, and sometimes you have answers in your mind when you wake up. And they actually have some scientists who actually describe that kind of thinking. They actually have the answer when they wake up from a very long night of sleeping. At the same time, if you think about it, what you think about right before you go to sleep also gives you nightmares. So if you are a person who has a lot of nightmares, then you should start changing what you think about right before you go to sleep. If you're going over with all the bad things that happened to you that day, you tend to have bad thoughts when you go to sleep, and you tend to resolve them in your REM, which can give you severe nightmares. If you instead think positive thoughts, it can alter the way you sleep, and you can actually wake up and feel rested and actually feel like you've resolved some of the problems. So again, sometimes just knowing that little difference can help you. Pediatrics and sleep, newborns sleep about 16 to 17 hours per day. Since I've had 6 kids, I can't really believe that. It always seems like the only times they're awake is when I'm awake, or I'm trying to sleep. So I've never seen kids, seem to hold 17 hours of sleep. So maybe they're doing while you're running around totally awake, and when you're trying to get your rest is when they wake up. Okay, 53% of their time they spend in active REM sleep. So REM is very important for their learning purposes. They're resolving complex issues that they're trying to understand what they're seeing. The infant sleep cycle can be as prolonged as 50 to 60 minutes. So that's a very long REM sleep. Okay? Infants enter REM almost immediately upon falling asleep, which is also very different than adults, okay? Which takes us about an hour, hour and a half before we ever even enter into REM sleep. Okay? Actually, if you enter into REM sleep and you wake out of it in the middle of REM sleep, you wake up exhausted. Okay? So when people tell you to take a power nap, what you're going into is you're going into non-REM sleep for less than 30 minutes, and when you wake up, you feel fairly rested. Okay, it's not as good as somebody who's gone through a 1 REM cycle. Then you really feel very, not tired. But if you wake up in the middle of REM, you feel actually very beat up. You feel exhausted. Okay, I don't know how many people have done that When you go on call, you'll feel that. You'll go on for 90 minutes. You'll be thinking, oh, I'm just going to sleep the rest of the night. And the beeper will go off, and you'll wake up and go, oh, my God, I feel like I got run over by a truck. Okay? And it's simply because you got woken up during a REM sleep. It's not something that you just learn to get around it, that's all. That's part of why you're put on call. So you get to experience the whole beauty of being disturbed in your sleep. Okay? As a good thing is, as you get older, in my age group, your total sleep time is significantly decreased. I've been trained since I was in medical school to sleep with around 4 hours a night. And that's all I sleep, okay, most of the time. Sometimes it catches up to me, but most of the time when I was younger, it used to catch up to me a lot more. So I've noticed as I've gotten older in the last 4 or 5 years that I'm actually going to 4 hours sleep, and I actually feel fairly comfortable. So most of you are still younger, so you're sleeping 8 hours a day. So when you're going up to 4 hours, you're dying. So, but by the time you get to be 55, 45 years of age, you'll start noticing that your actual sleep time is significantly diminished. Elderly also take longer to fall asleep. It could be that they have a lot of things they're thinking about. It also could be that they have other things that are keeping them awake. The worst thing to do is sleep with the television on. That's really not helping you fall asleep. Okay? And you're waking more frequently during the night. The amount of time to sleep in stage 4 significantly decreases as well. The potential causes of physical ailment, lack of daily activity, circadian rhythms are being changed, and medications that the patient may be on. There's different kinds of sleep disorders that you may encounter. Disorders initiating sleep, which is called insomnia. Sleep-disordered breathing is ones that you have to worry about the most. Okay, these are the kind of situations where you can actually induce apnea and death in a patient immediately post-op. Unfortunately, the anesthetics actually increase the inhibition of apnea. So these people are much more likely to develop apnea after anesthesia. So upper airway resistance syndrome, obstructive sleep apnea, obesity hypoventilation syndrome, also called, what's it called now? I don't remember the name, but it's Ondine's curse is also obesity hypoventilation syndrome. All these can cause the person to develop apnea when they're asleep. Disorders of sleep and wake cycle or parasomnias, where actually patients can actually wake up in the middle of a sleep, and they are asleep, and they walk around the house. Sonambulism, night terrors, and enuresis is very common. You see this in children a lot, okay? And this is not that's pathological. Some kids do this, and they're actually totally normal kids. And you just got to learn to lock them, up so they don't walk and hurt themselves in the night. They've actually had kids that have actually walked out in front of trucks and outside the house. So you got to make sure that the house is locked up so these kids don't roam around while they're sleeping. And they don't know where they're at. You can actually talk to them. I had one of my 6 kids did this, one of my youngest daughters, and she did that for about a year. Then it stopped, thank goodness. But it was funny. You see her walking around the house, and I usually stay up late anyways working, so I would see her walking around and say, "What are you doing?" She would look at me kind of funny, and she would keep walking. I didn't even know who I was. So I'd come up to her and talk to her again, and then redirect her back into her bed, and she'd go right back and go put her head back down. She was instantaneously asleep. She would never woke up. When you asked her the next day, "Do you remember walking around?" She said, "Nope, not at all." So, and when I went back and read about this stuff, it's very common in that age group. She was around 10 at that age, and it goes away usually in about 1 or 2 years sometimes. So they think it's a developmental issue in the brain that eventually gets suppressed. It's not adequate suppression of the REM cycle. So these kids are actually having REM, but they're actually walking when they're REM. Normally REM suppresses your muscle activity, so the only thing you see is eye motion, but the rest of the body stops moving. If you see people when they're having REM, they should stay completely still. When you're seeing them moving, that's considered non-REM sleep most of the time. Sleep and disease, secondary sleep disorders, you can get alterations in the quality or the quantity of sleep due to primary diseases. You get depression, pain, sleep apnea syndromes, and alterations in thyroid hormone secretion can also alter the sleep cycle quite a bit. And you get sleep-provoked disorders, which are sleep stage alterations produced in certain disease states that also can affect how the person sleeps adequately. Now, when we talk about this, when people tell you that they're not sleeping well, That means they're more prone to having problems when they get anesthetics. They're much more sensitized to go to sleep. Okay? It doesn't mean that they have an increased tolerance to the anesthetic. Actually, they have a decreased tolerance. So a lot of times they get a sensitization, okay? Because the brain just trying to find something to be suppressed. And once they are suppressed, they stay suppressed for prolonged periods of time. Kids with that sleep apnea syndrome is going to be very at risk for developing apnea for long periods of time. So anybody that's a neonate that's prematurely born, okay, tends to have a sleep center that's not properly conditioned for approximately years of age, 7 or 8. So you put these kids to sleep, you need to watch them at least for a good 4 or 5 hours to make sure that all the anesthetics are out of the system so the kid doesn't go apneic and develop SIDS, which is sudden infant death syndrome immediately post-op. So you got to be really aware of that. So one of the things that you take care of kids, always ask, were you born premature? Once you're beyond 7 years of age, that the issue resolves itself. The brain develops more normally at that point. But between the ages of 0 to 7, you've got to be concerned about apneic problems post-op. Then we go into the eye. The eye is your major sensory organ that gets information from the environment. Okay? It acts basically like a camera that reverses the image. It uses a lens to actually allow light to come in, and it forms an image in the macula fovea, okay, which is the area that's highest concentration in rods and cones. There's different things that you have to be aware of that may actually cause you problems as the actual person delivering anesthesia. You don't want to get eye infections and pass them on to yourself. Sometimes you'll get things like this, which are inflammations of the eye. This is not something that's usually associated with an infectious process, but rather just it's inflammation due to exposure to something. Then you get what's called a hordeolum, which is a stye, which is an infection in the sebaceous gland of the eyelids. Usually this is not something you have to worry about as well, in the sense that it doesn't pass on to you most of the time. The chlamydia is an infection in the Moebian oil-secreting gland, which can cause, again, problems for the patient, but not usually for you. But then you have something like this, which is a keratitis. Okay? It's an infection in the cornea. This is why we tell you be very careful about using contacts in the operating room. Okay? This is from a resident, okay, who was exposed to bacterial fluid while she had contacts in her eyes. Okay? The surgeon basically was opening up the abdomen, and the abdomen was grossly infected with E. coli. Okay? And when it opened up the abdomen, all this free fluid splashed up all over the field, and she was in the anesthesia side of it, but she was looking directly at the field, and it got in her eyes. And what she did was she just blinked and just thought everything was fine. Okay? Unfortunately, she was on call that night and did not remove her contacts the next morning. Did not remove her contacts that night. And what happened overnight was the E. coli embedded into the actual contact lenses and her cornea. Okay? And when they actually finally removed, because she had severe keratitis like this, is when they removed the contact lenses, they actually sheared off a part of the cornea. Not something good, to say the least. Okay? So she ended up being blind in one eye until she got a corneal transplant. Okay? This is not a joke. So if you decide to wear contacts in the medical field, okay, just beware that you should be wearing glasses to protect your eyes. Okay? So anytime you're exposure to possible liquid interface, make sure that you have your contacts covered by some form of glasses. If you feel anything splash in your eye and you have contacts, take your contacts out immediately and replace them with another set. So you should always have a secondary set with you. And do not sleep with contacts. If you're one of the person that sleeps in these things with once a week, and if you're in the medical facility, job like you're doing right now, I would just switch it over to the dailies. So every day you just throw them away and just get a new one. Okay, it's just not worth your eye life to have this kind of problem. Okay, all my kids, I have 3 of my kids that are on contacts, so I get them dailies, because I don't believe in kids can actually do a good enough job of cleaning their contacts. So it's just worth it to me not to have them have this problem. Okay, you can also get conjunctivitis, which is inflammation of the conjunctiva. It's usually due to acute bacterial infections, usually called pink eye. It's just highly contagious. It causes a mucopurulent drainage from one or both eyes. Anybody who's got a pink eye can't come to the operating room and take care of patients. So if you get infected with pink eye, then you need to get treated with antibiotics until that clears up, because you'll pass on that infection to everybody that you come in contact with. Viral conjunctivitis as well. Allergic conjunctivitis is different. Of course, it's due to exposure to something. Trachoma, chlamydial conjunctivitis, is difficult to treat. What you see, this is a viral conjunctivitis. You can see the inflammation and the erythema around the conjunctiva. The eye, of course, is very important for transmitting light into something that's a signal that the body can actually process and identify as an image. It uses rods and cones to differentiate between black and white and color. From that, it then sends the information back via these nerve fibers all the way past into the actual primary visual fields. In the process of doing this, the eye is able to differentiate which portion of the field it's looking at. If you look in the green side, which is the right visual field, it's looking at it from this aspect of the eye and this aspect of the eye. Okay? And what you'll see is that this will eventually combine to one side, and then it gets integrated into the visual fields. The reason that's important is because your eyes are seeing the same image at a slightly different angle. Okay? That ability to do that gives you the ability to see depth. Okay? And you're only seeing depth in one thing you're concentrating on is the only thing you're looking at. And you can tell depth very accurately to up to 1 centimeter if you're trained properly. Okay? You can actually have a builder, and he can look at a wall and tell you within 1 centimeter how much of the wall is off by. Okay? That's how fine an eye can be. Okay? That's pretty good. Okay? Some people can go down to the millimeters from what I've read. But most people can do it pretty quickly down to the 1 centimeter mark. Okay, so it's pretty accurate. Okay? Now, the other important thing about knowing that is that it's giving you a visual field that's everything from this area here is coming in contact with this portion of the brain. Okay? So if you had your hand over here, okay, and you were exposed to a lion and he's going to bite on your hand, it's better to see that visually coming at you, and then that information would get conveyed to the area of the brain up here, which then sends it to the motor, which then sends the information down to that hand. That's why everything is contralateral to the side that is affected. Most likely it's due to your visual fields. Okay? Now, when it goes to the optic chiasm, which is this location, if you cut this in this location right there, you can cause the inner portion of the eyes not to be able to see, which means that the lateral aspects of the field get lost. So the peripheral fields are disappeared in that person. Okay, the inner portions of the fields are still intact. So different cuttings or different injury patterns will give you different kinds of visual field disturbances. Okay. Vision changes with aging as well. You get the cornea will become thickened. The anterior chamber, the lens, ciliary muscles, all in the retina as well change with age. You also get visual dysfunctions. It can be from lack of ocular movement. Okay, in a child that gets strabismus, you get this lack of muscle control, and the kid will eventually lose sight at the age of 3 to 5. Okay, so you have to pick this up early if you're a parent. Okay, and this has a genetic variability to it. If you have a family member with a lazy eye, the chances of you having that in your children goes way up. Okay, so it's something that occurs in families, so you have to look for it. Okay, so if you have families, history of one person being blind in one eye, it's usually from strabismus. Okay, the person will develop an inability to focus on something, so instead of the brain being constantly confused, the kid will basically shut down that eye permanently and will be blind in that eye. Okay, and the eye to them will drift, but they can't use that eye at all to see. Okay, one of my daughters had this problem, and she resolved this. It's actually her picture. It resolved after she had strabismus surgery and repaired. So it can be repaired, and it's wonderful how it changes her life. This child never played with video games while all of her other sisters and brothers played video games. And soon after the operation, within about 12 hours, she asked me, "Dad, can I play games?" I said, "Yeah, sure." And sure enough, she could actually track with her eyes 24 hours after the operation, and she enjoyed the games then. Before that, it would just cause her headaches, and she couldn't focus on things. But the good thing is she didn't lose her visual field on that. If you wait too long and you're not aware of it at the age of 3 or 5, they will lose that eye permanently, and you can't get it back. So you want to stay on top of that and watch your kids. And even the pediatricians, which we got to see them 3 times a year, never picked up that she had strabismus until my wife noticed it. So, if you see your kid going inwards, it could be that you have strabismus problems and you have to deal with it. Nystagmus is a pendular nystagmus may also occur, or jerk nystagmus, which means the muscles are usually due to inability for the sympathetic property functioning work, and you get this jerking motion, which is a little bit more difficult to treat. Visual dysfunctions can also be amblyopia, scotoma, retrobulbar neuritis, and cataracts. All these are things that you end up dealing with in the operating room, especially cataracts. We do a lot of cataract replacements. These used to be major surgeries in the past, and they really developed this very almost outpatient mobility now that you can do these. Visual dysfunctions, also things that you have to worry about specifically is a thing called papilledema. Okay? Papilledema is one of those nomenclatures that you got to know from heart from now on. Okay? The reason being is you're going to be putting in spinals or epidurals in patients. Okay? If you read ever in a note that a patient has papilledema, it means that they have a raised intracranial pressure. Okay? What you'll see with papilledema is this optic nerve right here. Okay? That normally is, like you see it right here, okay, is very sharp in its outlook. Okay? Yeah. I won't raise it. Okay, anyways. You normally see it that the actual arteries going over the optic disc area is very sharp. Okay? And papilledema, because you get pressure put in behind it, because the actual CSF goes up all the way against the back of the eye, it'll begin to push this retinal area forward. And as a consequence, you'll lose that sharpness. So instead of being able to see the whole field as being sharp and focused, you'll begin to see that the artery looks like it's coming at you and it gets blurred because you can't seem to focus it. That's called papilledema. Okay? So papilledema means that you have intracranial pressure that's raised, and if you put a spinal or an epidural and it gets wet tapped, that person may actually herniate and kill them in the process. So it's a contraindication to doing a spinal or an epidural. Okay? So papilledema is one of those eye signs that are really pretty important for us. Dark adaptation, of course, is something that happens in some people due to vitamin deficiencies. Vitamin A deficiencies can cause visual field dark adaptation problems. If you have a person who complains that they don't see well at night, they have a much higher incidence of having nausea and vomiting post-operatively as well. There's a much higher incidence of almost 60% of having nausea or vomiting. So it's a very easy question. Do you have problems with night vision? If the person tells you yes, and they've never had an anesthetic exposure before, then you need to try to pre-treat them as aggressively as possible so you don't get nausea or vomiting post-op. Glaucoma is an alteration in intraocular pressure, which then causes retinal damage, okay, which basically will begin to impede the blood flow to the retina. And then you have what's called age-related macular degeneration, which leads to blindness in the patient. You can also get alterations on accommodation. Accommodation is a process whereby the thickness of the lens is changed, and this is an oculomotor nerve changes. It decreases the flexibility of the lens. This actually happens normally with age. Its manifestations include diplopia, blurred vision, and headaches. You may also get refraction errors, which is myopias, hyperopias, and astigmatism. Of course, these are all things why you go to optometrists for. This is the kind of things you'll see. You'll see normally that the eye should focus it on the retina. Okay, if you see in different forms, you can see that the eye will be focused posteriorly to it. That's why you put glasses on people, or too anterior to it. Visual dysfunctions look at alterations in color vision. You can have men tend to be much more color blind than women because it's generally an X-linked recessive trait, and men only have one X gene. They have an XY versus women have two X's, so usually men are the ones that get the color blindness. The most common is red-green color blindness. Neurological disorders include hemianopia, or injury to the optic chiasm, or what's called homonymous hemianopsia. What I ask you on the test is basically the following. Okay, I expect you to know these because this involves, when we talk about pituitary tumors, and we talk about certain forms of blindness. So what I want you to do is take this picture here and associate it with the actual visual loss. Okay, if you see number 1 here, okay, this is a nerve cut, okay, and that correlates with one lesion of the right optic nerve, and you get right eye blindness. If you go to 2, which is a cut here in the optic chiasm, okay, then you get lesion in the bitemporal hemianopsia, which means that you lose your lateral vision. Okay, so you still see the inside. Sorry, let's see if I got this right. No, you lose your lateral vision with both those. Okay, with the so number 2 is a lesion where you lose your lateral vision. Okay, so the darkness there, and then 3 is back here is the left optic chiasm tract lesion leads to a bilateral right hemianopia. Okay, so you get both sides, or you're losing your vision out here. Okay, so and it gets more complicated than that, but don't go into this one. This is more for if you really are interested in this, that you can get different kinds of visual field losses. This is what I want you to know for the test, the first 3. Get those down pat first. Okay. The ear is basically something that you have to understand to somewhat, because we do put in PE tubes in kids, okay, which what you have in the middle ear, okay, this is the outer ear, middle ear, and inner ear, okay. The outer ear, of course, can get infected with exposure to some kind of water or things like that. Then the middle ear is more of a concern, because then you can get purulence that can develop, and then it can't drain out. And what we do to help drain it is if it's not draining properly through the Eustachian tube, which is small in little kids and it can scarify due to bacterial infection, is then we put a small tube through the tympanic membrane to drain the pus out of the middle ear. Okay? One of the things that develops, because it is a partially closed space, is that nitrous oxide can go into the space and tint it very severely, and it can make it very tight in here. It can add to nausea and vomiting post-operatively. If you have a person who's had a tympanic membrane replacement, okay, which is a skin flap that you put in, usually from a tendon, and you give that person nitrous oxide, you can actually tear it apart, and then the person will be back to be deaf again. So not something you want to do. So contraindication to using nitrous oxide. The middle ear goes into the inner ear, which is responsible for the actual control of positioning as well as being able to hear. So that goes into a complicated format, causing severe nausea and vomiting. If you lose the ability of where the actual little stones are at in your inner ear, then you lose the ability to know where your head is at in space. There's different maneuvers you can actually use at times, because some people can actually wake up from anesthetic, especially somebody whose head's been moved a lot during the case. The little stones in the ear can actually be shifted, and then the person wakes up and their head's spinning. And you can ask very simply, is your head spinning when you're looking, or is your head spinning when you close your eyes? If they say they close their eyes, the head's spinning, it's usually due to non-ocular activation, which is from the middle ear, from the inner ear. So that's one thing you have to repair before you send that patient on. And there's different maneuvers we can teach you how to do to reverse that effect. You can turn the head a certain way, and then you tilt the table, and you can make the little stones in the inner ear to go back in place, and then all of a sudden this problem goes away. Aging and hearing, the cochlear hair cells degenerate as you get older. There's loss of auditory neurons and spiral ganglia, and you get a degeneration of the cochlea. You get decreased vascularity of the cochlea as well, or loss of cortical auditory neurons. So there's lots of reasons why you tend to go deaf as you get older. The ear infections that we have to deal with is either otitis externa or otitis media. Otitis media is the one that we have to deal with mostly because otitis externa is fairly easy to treat. Okay? Usually it's a swimmer's ear. It's due to prolonged exposure to moisture. Usually alcohol treatment is given. The alcohol is not there to treat the problem. It's rather to dehydrate the area, help remove the water out of the ear. You can't go crazy on it. You can get too much. But just put a little bit in there, because sometimes we'll pull all the water out of there. The downside to using alcohol, of course, is that it begins to affect the actual wax production, and it sort of helps, which is the wax helps keep the water out, keeps it dry. So giving too much of alcohol can actually prolong the problem for it happening again. Otitis media is basically an infection usually that occurs in the middle ear and can cause significant effusion, including purulence, to develop. This is what you deal with here. Okay, this is an example of where we actually will, the stapes is here. Okay, this is where the actual the bone is connected up to the tympanic membrane, and the vibration of this drum effect, when the air hits it, is what allows the person to hear. It causes this bone to move, and it causes this signal to be transduced. Okay, what we actually do for this kind of procedure is that we put a hole here, and then we put a little tube in here. You can see this person has very severe infection. And you can see the purulence. You can see actually the middle ear is bobbing out at you. And so when you actually put a hole in this, okay, and you drain it, you'll see actually purulent material coming out. Okay. If you wait too long, you'll get scarification like this. This is extensive scarring of the tympanic membrane, and this kid will now have problems with hearing after that. So you don't want to be to the point that it's getting chronically infected and now scarred. You can get conduction hearing loss, which is impairment of sound conduction, which is what I was just talking about. You affect the tympanic membrane. You may also have sensorineural hearing loss, which is impairment of the organ of Corti or central connections. Okay, you get mixed hearing loss or functional hearing losses can occur as well. The last part we'll talk about is olfaction, and we'll stop at this point, I think. Olfaction has to do with cranial nerve number 1 and part of cranial nerve number 5. It's a strong relationship between taste and smell. It's actually the most important part of tasting things is actually olfaction. If you have olfactory stimulants, there's many different reasons that there's about 2,000 different things you can identify with your nose if you're trained properly. Most of us will be able to train to basically pick out apart about 20 different things, but other people that are very heavily trained will actually be able to tell you exactly what they're sniffing. And actually, some people make their living doing this, like wine tasters. Okay? The taste is actually from cranial nerve number 7 and part of number 9. It's nerves in the tongue, soft palate, uvula, pharynx, and upper esophagus. You can only taste 4 different things. That's all you can taste. You only taste sour, bitter, salty, and sweet. That's the only thing that you can taste. So if your palate is diffuse of the olfaction, then you really can't enjoy your food very much. Okay. Age-related olfaction and taste changes. Olfaction declines in odor sensitivity. There's a loss of olfactory sensory neurons. Okay. Taste is a higher concentration of flavors is required, and decline in the number of fungiform papillae is also evident. If you notice that as people get older, their actual their taste for more stronger foods becomes almost something that they do very commonly. Versus if you see younger people eating certain kinds of foods, they'll stay away from these very strong tastes because to them it's overwhelming. Versus as you get older, it's almost like that. That's what you need to just stimulate you. So as you get older, the way you eat changes. One of the things that's important for you to know is if you have somebody who develops no sense of taste at all, it's usually an indication that you have a hypomagnesemia. Okay? And usually concomitantly with hypomagnesemia is a hypokalemia. Okay? Because hypokalemia will not be reversed unless your hypomagnesemia is reversed first. So that's important clinically. If you have somebody who comes in pre-op and says, hey, I don't taste my food anymore, the first thing you should do is get a magnesium level as well as potassium level on that patient. Because invariably they're hypomagnesemic. Okay. Olfactory dysfunction will cause hyposmia, anosmia, which means no taste at all. Olfactory hallucinations, which is something strange, to say the least. Imagine smelling things that don't really exist. And parosmia. Okay. Taste dysfunctions, of course, are different things that you get, which we're not going to talk into in any detail. Somatosensory dysfunctions occur due to sensations involving modality, intensity, location. You can get receptors are present in the skin, so touch is something that you would perceive. Some people have diminished levels of touch, and other people have increased. Proprioception, on the other hand, depends on inner ear, vision, and receptors in joints and ligaments. This is a very important receptor function because it loads the muscle beforehand based on the stress load that's put on it. Okay. Now, why is that important for us clinically? Well, let me give you an idea. Okay. Proprioception is responsible for diaphragmatic function. Okay, the diaphragmatic load that your diaphragm is put under adjusts very rapidly to try to maintain a normal diaphragmatic tone. Okay? If I switch position from one position to the next, and I begin to stretch the diaphragm more on one side in comparison to the other, this feedback mechanism immediately increases the tone to the one that has the most stress put on it, which brings the diaphragm back to a normal location so it's able to excurge more efficiently. Okay? Without having that proprioception ability, then the diaphragm begins to become ineffective, and you will see a bigger amount of ventilation to perfusion mismatch, which is something that you will see when we deliver an anesthetic. As soon as you deliver any form of anesthesia, benzodiazepine, Versed, without even using neuromuscular relaxants, okay, you can actually impair this proprioception information coming back from the diaphragm. So as soon as you put somebody under general anesthesia of any kind, okay, you're basically impairing the proprioceptions, and as a consequence, you decrease the effectiveness of the lung function. And we're going to talk about that more in respiratory when we get to it. Okay. And we'll just